ചങ്ങായി പറഞ്ഞു ഡിസ്കസ് ചെയ്തു. അതിന് ഗൈനക്കിലെ ചങ്ങായി നേരത്തെ പോകുമ്പോൾ ഒരു ഒപ്പിട്ട് പോയേക്കെന്ന് പറയുന്നുണ്ട്. അതൊക്കെ ഒപ്പ് കിട്ടണം, അത്രേ ഉള്ളൂ.
ഇതിപ്പോ ഞാനും നിങ്ങളെ പ്രവീൺ ഒന്ന് സമ്മതിച്ചു പോയതല്ലേന്ന് പറയാം.
അല്ല അവർക്കത്ര
വേണ്ട. പിന്നെ അവിടെ
ചോദിക്കാൻ
ആരോട്
ഇവർക്കൊക്കെ ഒരു മാപ്പ് കിട്ടിയിട്ടുണ്ട്, കിട്ടിയിട്ടില്ല. ഒരു പ്ലാൻ
ഇല്ലല്ല,
ഒരു മറ്റേ പ്ലാൻ വരച്ചിട്ട് അത് ഇവരുടെ കയ്യിലൊക്കെ ഉണ്ടാവും. ഞാൻ ഇതെവിടെ കിട്ടിയിട്ട് ചോടി തന്നതാണ്.
ഏത് ഡിപ്പാർട്ട്മെന്റ്?
ഗൈനക്കിലെ സെക്കൻഡ് എടുത്ത് ഈ കൈ
എന്റെ കയ്യിലൊന്നും ഇല്ലല്ലോ. കഴിഞ്ഞ 3 ദിവസം വന്നിട്ടുണ്ടായത് തപാല്.
ചിലപ്പോ അതുപോലെ വന്നിട്ടുണ്ടാവും. എല്ലാവരുടെ അടുത്തും
നീ ഒന്ന് ഷിജിനോട് ചോദിക്കണേ.
അല്ല ഷിജിനോട് ചോദിക്കും. ഷിജിൻ ഞാൻ ചോദിക്കലുണ്ട് ഷിജിനോട്
എന്തെങ്കിലും ഉണ്ടോ ചോദിക്കണേ.
പൊട്ടനാ ഷിജിൻ
കുറച്ചല്ല നല്ലത്
എടുക്കാനാണ് ഞാൻ. പക്ഷെ 2-3 കാര്യം ഞാൻ ചോദിച്ചിട്ട് ഇവൻ പകുതി ചെയ്തു വെച്ചു. വൈകുന്നേരം പിന്നെയും വിളിക്കാം ഷിജിനെ. ഞാൻ പറഞ്ഞപ്പോ സാറേ ഞാനത് മറന്നുപോയി. അപ്പൊ ഞാനത് അതൊക്കെ നമുക്ക് 2 ദിവസം മതി ഒരാളെ.
കുട്ടികളിയുണ്ട്,
ചെറിയൊരു ഇതുണ്ടാകും.
അവന് പിന്നെ എന്നെ പേടിച്ചിട്ട് നല്ല കോൺസെൻട്രേഷനോട് കൂടി ചെയ്യുന്നതാ. പോയി
അറിയാൻ പറ്റില്ല.
വേണ്ടേ എന്റെ ബ്ലൂടൂത്ത് ഓഫ് ചെയ്യണം. എന്റെ കണക്ട് ആയിട്ടുണ്ട്. നിങ്ങൾക്ക് ആവശ്യമില്ല. അമ്മ ഇതിന്റെ ആവശ്യം ഇങ്ങനെയാണ്. നമ്മങ്ങനെ കൂടുതൽ ഉണ്ടാവില്ലേ. നമ്മളെ വൈഫ് എടുക്കണ്ടേ. നമുക്ക് സ്പീഡ് പോകും. യൂട്യൂബ് കിട്ടുന്നില്ല. അത് ചെറിയ ഫോണുണ്ട്.
Gopika madam, 5 minutes wait ചെയ്താലും 7:30 5 minutes കൂടെ.
Okay, 5 minutes കൂടെ വെയിറ്റ് ചെയ്യാം.
എന്താ ഇവിടെ ചെയ്യുന്നത്? പഠിക്കുന്നു, ഞാനും പഠിക്കുന്നു.
ബെന്നു തുടങ്ങിയല്ലോ. കൽപ്പന മാമും ഗുഡ് മോർണിംഗ്, ഗുഡ് ഈവനിങ് മാഡം.
ഗുഡ് ഈവനിങ്.
മാഡം നമുക്ക് തുടങ്ങാം.
നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാം. സമയം കളി.
ഡോക്ടർ ലക്ഷ്മി ഉണ്ടെന്ന് തോന്നുന്നു അല്ലേ?
But I think she's traveling. Traveling. Okay. So, good evening to one and all. On behalf of IAP Thiruvananthapuram and IAP Kerala, we welcome you all to this wonderful teaching program. That is our beloved State Presidential Action Plan. That's 2024. And this time, IAP Thiruvananthapuram is hosting it. And we have an interesting case that is awaiting all of you. So, without further delay, I call upon our IAP State Vice President, Dr. Prashant Pavitran sir, to give the keynote address. Over to Prashant sir.
Yeah, just got in, Benno.
Yes, sir.
Respected President, IAP Thiruvananthapuram, Dr. Benno, respected President Dr. Hari Prasad, Secretary Dr. Benno, Treasurer Dr. Rosemary, and all best wishes to the IAP PG teaching program. It is conducted by IAP Thiruvananthapuram and IAP Kerala Presidential Action Plan. Thiruvananthapuram has been in the thick of academics on Tuesday and Thursday. It's filled with academics, and best wishes to this program of IAP Kerala and IAP Thiruvananthapuram. Thank you.
Thank you very much, sir. So, without further delay, I would like to call upon our mentor for the day. That is Dr. Gopika Sekhar. Madam is Senior Consult Pediatrician at Anandaburi Hospital and is also our IAP Thiruvananthapuram Joint Secretary. So, I invite our mentor, Dr. Gopika Sekhar, to kindly introduce the chairperson as well as the case presenter. Over to
Thank you,
Gopika.
Ben. Thank you, Benno. So I am very glad to introduce the chairperson for this PG teaching session today. The chairperson is Dr. Kalpana, none other than Dr. Kalpana ma'am, and she is now senior consultant in pediatric neurology, KIMS Health Trivandrum. Madam is well known to our pediatric community. She has many years of experience in the field of pediatric neurology, and she is a much sought after clinician as well as an academician. And I am glad that Madam has agreed to chair this session for us. And I am sure that this will provide many learning points for our young residents. And the presenter today is Dr. Asif, a senior resident in pediatric neurology in our department, Anandaburi Hospital. And he is also a very hardworking student. He is now cleared his theory exam and is waiting for the practical. And I wish him all the best in this today's session as well as in future endeavors. Over to Asif.
The screen share.
Screen sharing ചെയ്യാം. I think I'll just mute everyone so that it will be trouble free.
Kalpana madam.
ഞാൻ കൽപ്പന മാഡത്തിനെയും co-host ആക്കാം. ആസിഫിനെ അൺമ്യൂട്ട് ചെയ്യാം.
Start yours.
Yeah, start it.
Good evening, all. I am Dr. Asif. I am a DNP resident in Anandpur Hospital and Research Institute. I am going to present a case. A 9-year-old male child coming from Parashala, Thiruvananthapuram. He was admitted on 13th December 23 and he was examined on 23rd December for 10th post-admission day. And the informant was parents and was reliable. His chief presenting complaints were cough and runny nose for 1 week, fever, vomiting, headache for 5 days, abdominal pain for 3 days, weakness of both lower limb and altered behavior for 2 days. History of presenting illness. The child was apparently normal till 1 week back and he developed cough and running nose and he was consulted at a local hospital and treated symptomatically. The cough was dry and non-productive in nature with no postural or diurnal variations. He then developed fever, which was a high-grade intermittent with chills and rigor. Along with the fever, he had multiple episodes of non-bilious, non-projectile vomiting, and it was not associated with nausea, loose stools, abdominal distension, or anuria. He also had a headache along with the fever, vomiting, more in the front and back of this scalp, both sides moderate intensity with no diurnal variation or aggravating factors, but which improved after vomiting. After 2 days, he developed diffuse abdominal pain along with the fever and vomiting, which was a moderate intensity, colic in nature, no radiating or no aggravating factors, but partially relieved with the medications. He had no seizures or any abnormal body movements. So the child was tired and was taken to a nearby hospital and routine investigations and ultrasound abdomen was taken and the child was admitted and treated with the antibiotics. Since symptoms persisted, the CT scan abdomen was taken and they told that he had probably appendicitis and the child was kept nil orally with IV fluids were given and IV injection for fever. The next day, the parents noticed that the child was not able to stand on his own and his knees were buckling. The mother also noticed abnormal behavior in the form of irrelevant speech and irritability. And he also had constipation and bladder dysfunction in the form of urinary retention. With these symptoms, the child was referred to Anandapuri Hospital for further evaluation and management. The course in the hospital, the child was admitted in PICU. MRI brain and spinal cord was done, followed by lumbar puncture, and the weakness progressed to both upper limb and the child became drowsy with the pooling of secretions, slurring of speech, and cough while feeding. Hence, he was ventilated on the 3rd day of admission and treated with the costly medication for 5 days. He was also started on tube feeding. On the 5th day of mechanical ventilation, the child had showed improvement in his sensorium in the form of spontaneous eye opening, and the weakness was improved in the upper limb, and hence the child was extubated. He was on mechanical ventilator for 6 days and on a non-invasive ventilation for 2 days post extubation. He was not able to feed himself, hold objects tightly in hands, not able to roll over or sit or stand. There was no history of any rashes or suggestive of meningococcemia, dengue fever, measles, or rubella. There is no history of dog bites suggestive of rabies. There is no history of any vaccination prior to the event suggestive of vaccine-associated demyelination. There is no history of contact with the TB. There is no history of travel to an endemic area suggestive of malaria. There is no history of trauma. No history of similar events in the family. Past history.
Okay. Can we stop here?
Okay, ma'am.
Okay. So regarding the symptoms, the first presentation was with a cough and running nose. That was like a non-specific upper respiratory infection that lasted for 2 or 3 days, isn't it?
1 week.
And 3-4 days, child was asymptomatic, and then the child developed fever, vomiting, and headache, isn't it?
Yes, ma'am.
And then the abdominal pain developed, and So the history of these should be in detail. Actually, in this case, it may not be that much possible, but still, because along with the abdominal pain, he also developed weakness of both lower limbs. And then he developed urinary retention. So we have to combine these two, and then we have to discuss, like, so abdominal pain along with the weakness of limb. So what will you think of?
Acute onset of abdominal pain with weakness, there's chance of spinal cord lesions like transverse myelitis.
That is because you are thinking of the case. But when a child coming of abdominal pain, and then they are telling weakness, first thing is you have to take the history of abdominal pain in detail. So how the abdominal pain occurs in case of transverse myelitis or any spinal cord disease?
The pain usually from back to front, ma'am, and it will be continuous pain will be there.
What is described? What is the pain that is described? That is, there will be an area of decreased sensation. Above that, there will be a band of hyperesthesia. Okay, so it will be like a band from the back to the front. And whenever somebody touches or somebody takes the baby, the child will be crying. Or even the dress touching on that area, the child will be having pain. So the pain can increase intermittently, often when somebody holds the child or when somebody takes the child. That is, or even changing the clothes or changing the sheet, like that. So that area is having a hyperesthesia. That will be the reason for the abdominal pain in this case, because of the other presenting symptoms. Then other thing is when a child is having a urinary retention, so there can be a pain because the child cannot pass urine and the bladder may be distended. So they may be complaining of some distension, some discomfort over the abdomen. That is one thing. Then abdominal pain, if it is due to a radicular pain, what will you get?
Ma'am, there will be radiation and usually asymmetric pain on one side.
Okay, so main important is when you are doing coughing, straining, like that. When there is a straining or coughing, suddenly there will be a radiating pain from the back to the front. Okay, so that will be the feature of a radicular pain. If it is a radicular pain, that will localize the lesion to that spinal segment. Here, it is not like a radicular pain. It may be a something like a hyperesthesia, some area which is when we touches or the pain may be more. So in between, the child may be complaining, like when the child starts to get up, there may be an increase in pain when his body is touching somewhere, like that. Then any condition where there is a weakness which is associated with the abdominal pain, and there can be a discoloration of urine.
Acute intermittent porphyria, ma'am?
Yes, acute intermittent porphyria. So all cases of flaccid paralysis, often we asked for that discoloration of urine also. So this child has abdominal pain and there is weakness. Weakness was in the lower limb and this was associated with the bladder retention.
Yes, ma'am.
Okay, so this can be a spinal cord involvement is possible in this child, giving the history like that. Then regarding the headache, it is a very non-specific symptoms only was mentioned. What will be the features of headache of raised ICT?
The headache will be very severe headache that mostly in the morning associated with the non-projectile vomiting, and the child may be irritable.
It is so it is
thrombic.
It's a projectile like vomiting, very forceful vomiting will be there in the early morning, and the vomiting will not the headache will not be subsided by the vomiting also. And it is in the early morning, because when the child lies down, the venous return increases, and so the headache, the intracranial tension will be higher, isn't it?
Yes.
It is the venous return is actually to the brain is more. It is not coming back because the child is in the lying down posture. So that is the reason why which you are getting the high amplitude intracranial pressure waves, and early morning headache will be there. That will be the feature of raised ACT headache. This is something like a non-specific headache, and it is some associated with the feed also sometimes, and contained food particle only. It is non-bilious, so obstruction chance is less. So associated with this type of headache, can occur in a CNS cause? A headache whenever the child takes food, or just every time headache is there, it is not associated with the raised ACT. So can this be there in any type of any part of brain that is affected when there is very significant vomiting?
Cyclical vomit, area postrema.
Yes, area postrema syndrome. That is a very good possibility. That is, so there the child will be having recurrent vomiting, sometimes associated with hiccup also, because the brain, the emetic center or the chemoreceptor trigger zone will be stimulated. So even some types of tumors also you can get like that. Recurrent vomiting, but features of raised ACT need not be there. So area postrema syndrome, when it is acute, it is one of the things. Then what else? Then the weakness progressed to the upper limb. So now the history is changing to going on to the upper limb, and then it is going on to developing weakness of the there is pooling of secretion, the oesolium is coming down, and there is some slurring. We don't know whether it is due to cerebellar involvement or not, but or it may be because of the palatal involvement itself. When it is palatal involvement, we will get a nasal twang of voice. If the respiratory muscles are involved, you can get a low voice volume, and child cannot speak without pauses. So many reasons can be there when there is a slurring or a decrease in voice volume. So now the lower limb weakness has ascended up, and then it is there are some signs of the involvement of medulla also. So one possibility may be the spinal cord symptoms, spinal cord involvement might have ascended up, or it may be a peripheral neuropathy like a GPS that is going up. Okay. So these are the two possibilities. So along with this, the negative things, what all things you have mentioned?
Ma'am, there is no.
And regarding this, you can say like no history of rashes, or if you want to tell something like suggestive of meningococcemia, dengue, measles, like that, you need not tell. You can say no history of any exanthems, you can say, or other rashes, butterfly rash, something like that. You can say that will tell you that it may be this one, not like suggestive of rabies, but some may be even hearing that there may be history like that. So you can just say that there is no history of dog bite. And then one more is visual impairment is one symptom that is important. For which all conditions?
Visual. Ma'am, I couldn't. I couldn't understand, ma'am.
If there is a child is telling that I am not seeing properly, when I am opening there is blurring, or one eye there is decreased vision. If there is a history like that, one eye or two eyes.
Blurring, there is a raised glaucoma like that.
Why? Because this is a child with the acute onset of weakness and
papilledema.
Papilledema, will it produce blurring?
No, ma'am.
Usually it will not produce. So when there is a blurring of vision, or vision is significantly affected, the thing you have to think about is optic neuritis. Okay. Optic neuritis occurs in Adam also, you can get MOG, isn't it? more type of edema, you can get bilateral optic neuritis. In neuromyelitis optica. Okay, we have said about the area postrema, isn't it? So the neuromyelitis optica, the optic neuritis plus myelitis. Okay, so visual impairment is very significant there. And also in multiple sclerosis, you can get one side alone can be affected usually. So visual impairment is one. Then other cranial nerve like ptosis and ophthalmoplegia. Okay. So ptosis and ophthalmoplegia or drooping of eyes, eye movement abnormalities, if diplopia, all these can show that there is a brainstem involvement. There are conditions like brainstem encephalitis. You might have heard of Miller-Fisher syndrome, where the weakness may not be this much severe, but ataxia may be severe so that the child may not walk. Okay. So ptosis, ophthalmoplegia, the Bickerstaff encephalitis or brainstem encephalitis is one. Miller-Fisher syndrome also you can think. And in neuromuscular causes like a very acute onset of myasthenia also, that is very, very unusual, but that also is a possibility. So ptosis, ophthalmoplegia. Then you have to tell about any facial deviation or facial involvement or difficulty in closing the eyes tightly, like that. So lower cranial nerves you have mentioned. So all that we can tell. And you can tell that is there any paresthesia or any sensory impairment. Okay. Okay, so all these negative things you can, as trauma is important, travel to endemic areas, the contact with TB is also very important, vaccination, that all should be mentioned. So first is we have to assess which all part of the neuraxis is involved, and then which are the parts that are not involved, that to localize where the lesion is. Then we have to think about the possible etiologies and tell about all the negative things in the regarding the etiology. Like that you can arrange. Just like we are arranging the examination finding. So you can tell about the first usually may not be, but second, then third, fourth and sixth. Then seventh you have to say, and then you have to tell about the lower cranial nerves. Then motor, definitely there is there. Sensory, you can say. Cerebellar, if the motor is not that severely affected, then you can tell about cerebellar. Then you can tell that is there any evidence, history of meningeal involvement, like any stiffness of the neck that was described. So that also you can say. Then you can tell about the negative history regarding the etiology. So that will be the way by which we will go off. Okay, next slide.
Past history. There is a history of a febrile seizure twice until 5 years of age and was on a Frisium prophylaxis. There is no history of any previous hospital admission. Antenatal, natal and postnatal history. It's a second child of a non-consanguineous marriage, born to a 35-year-old father and 28-year-old mother by spontaneous conception. It was a book case with a regular antenatal checkup. Oral iron, folic acid, calcium taken regularly. No history of GDM, gestational hypertension, bleeding or rashes. Natal history, the late preterm, 35-weeker. Birth weight is 1.7 kg, small for gestation. And child cried soon after birth and had a NICU admission for respiratory distress and was treated with oxygen for 1 week. Otherwise, postnatal event was uneventful. Dietary history, the child started on a breastfeeding and formula feed in newborn period and breastfeed continued for 2 years. Complementary feed started at 5 months and was on family pot at 1 year. Child is now non-vegetarian, consuming adequate calorie and protein, which is suggestive of any micronutrient deficiency. And on examination here, an NG feeds at present.
So what is the significance of this non-vegetarian in a child with a weakness?
A vegetarian, any vitamin B12 deficiency?
Yes, B12 deficiency, not in an acute case, but B12 deficiency is one that causes what symptoms it will cause?
Subacute degeneration of spinal cord.
Subacute combined
degeneration of spinal cord.
And by which are the tracts that are affected?
Posterior column. Posterior column is the initial affected.
Posterior column and the lateral
Lateral
column, that
column.
is the pyramidal tract. So
Mm.
pyramidal involvement with posterior column. So posterior column involvement, what history you will get?
The patient may not be able to stability, ma'am.
Like, so
Swaying.
but actually our position is maintained by our vestibular system, our visual system, and the posterior column. So when the visual stimuli is gone, so that when your eyes are closed, their balance will be gone. That is why we do the Romberg test, isn't it?
Yes.
But in what history we will get is that when they wash their face,
Yes.
wash basin sign, or when they are taking their bath, at that time they may not see and immediately they will lose the balance. So that is a history that you will get. Usually this is a seen in adult, now older children only. Okay, continue.
Developmental history. All developmental milestones, gross motor, fine motor, social, adaptive, vision, and hearing attained for age. Now, child is studying standard 4 with a good scholastic performance, good in sports and extracurricular activities. Immunization history, the full child was fully immunized up to age as per national immunization schedule, including JE vaccine. Last vaccine dose at 5 years of age. BCG scar was present. No additional vaccine as per IAP schedule was not taken. No AFA.
So the last vaccine dose is also important because a vaccine may precipitate a demyelination, vaccination. Okay. Continue.
Family history. There is no history of genetic disease, early stroke, cardiac disease in the family. No history of any similar complaints in the family. Father is 44-year-old, mother is 37-year-old, and elder sibling is 18-year-old. Socioeconomic history. Father is a mason and mother is homemaker, living in a Pakka house, belongs to lower middle class family as per the modified Kuppuswamy 2023. Summary. A 9-year-old male child born to a non-consanguineous marriage, late preterm, 35 week, with history of a NICU stay for 1 week for respiratory distress, with normal growth and development, immunized up to age as per the national immunization schedule, with history of cough and rhinitis, fever, vomiting, headache, and abdominal pain, followed by the progressive weakness, initially in the bilateral lower limb, then the upper limb, along with the cooling of secretions, slurring of speech, and altered sensorium. And the child was mechanically ventilated for 6 days, followed by non-invasive ventilation for 2 days, with improvement in sensorium and upper limb and lower limb weakness persisting.
The upper limb weakness has improved and the lower limb weakness was persisting, isn't it?
Yes, ma'am.
That was the history. Okay. So in this summary, this late preterm and NICU stay are not important in this case because the child is having a normal growth, development, good scholastic performance, and was no premorbid conditions. So that you can avoid, and then you can tell the other things bilateral. So fever, vomiting, headache, abdominal. So from this summary, what are the possibilities that you will think of?
Ma'am, acute onset of acute flaccid paralysis.
Okay.
With the involvement of the spinal cord along with the
acute flaccid paralysis involving both the lower limb, upper limb, and then what else?
And it may along with the brainstem involvement, ma'am.
Because pooling of secretions are there. So there is some palatal or a 9 and 10 involvement. And then there is a slurring of speech which may be due to the palatal involvement itself. And there is some alteration in sensorium. Mute here. Can you mute somebody else? Okay. So alteration in sensorium can, what can be the reason for the alteration of sensorium? Or what all can be the reasons for alteration of sensorium?
Fever, vomiting with headache, there may be acute encephalitis syndromes.
So it may be part of the encephalitis, okay. But usually encephalitis will produce a little more alteration, like may go in for coma like that, or seizures also may be more prominent. That is one. Any other possibility? A child with just acute flaccid paralysis having alteration in sensorium?
Ma'am, any demyelin?
Alteration in sensorium, what are the reasons for the? I'm not telling it is demyelinating, or I'm not telling it is an infective cause or whatever it is, but how the alteration of sensorium can happen.
Ma'am, any metabolic dearrangement?
In GBS, can you get an alteration of sensorium?
Usually not, ma'am.
Any difference in opinion? Anyone? Can you write also? You can write. So alteration in sensorium, if the respiratory muscles are involved, what will happen?
Breathing pattern will be changed, ma'am. So hypoxia,
Hypoxia, there may be
hypercapnia.
so there may be irritability. Then they may go in for drowsiness. That is one. Then, as Devi has written, it is Bickerstaff encephalitis or brainstem involvement. Brainstem involvement also, the reticular formation will be affected, and there can be alteration in sensorium. So without seizures, the alteration of sensorium can be because of the brainstem involvement also. Okay. So here, where will you localize the lesion?
Ma'am, with the history of fever with weakness, first I localize the lesion in the spinal cord, ma'am.
Is it because of the fever with weakness, or is it due to some other thing? There is weakness of the lower limb. Okay. Weakness of lower limb with bladder involvement, and with the area of there is an abdominal pain. The details we are not able to understand now. So there is an abdominal pain which is very severe because somebody said the thought of a surgical condition itself. So if it is an appendicular pain, appendicitis pain, how will be the pain?
Pain initially maybe it's a colicky type and mostly localized to the periumbilical region, then into the right ilia fossa. It may be associated with the loss of appetite, vomiting.
Okay, that all are there, isn't it? But the localization is not there. It is according to the history, it is a diffuse pain.
Yes,
so chance for an acute appendicitis is less, and when you are examining if the abdomen is soft also, the chance is very less, isn't it? So
yes,
you have to ask like that. And if you are thinking about, because this weakness was noticed only 1 day later, 1 or 2 days later only, that is why. And you said that there is some injections intramuscularly. Where was the injection given?
Ma'am, it was given in the gluteal region, and it was given in the anterolateral thigh.
So the anterolateral thigh you have to specify. If it is in the gluteal region, we'll think of what?
Sciatica.
Sciatica is different.
Means
the sciatic nerve may be injured.
So,
sciatic nerve is two nerves are joined together, isn't it? Tibial plus common peroneal, and the common peroneal will be the outer one. And usually in injection, the common peroneal part will be affected. And what will you get?
Foot drop.
You will get a foot drop. And you will have a severe paresthesia over the leg, the outer aspect of the leg as well as the foot. So if you are getting any history like that, you have to think of. Here, when the child is made to stand, there was buckling and child was not able to bear weight on both sides. So the chance is less. And previously, when the polio was rampant, when we are giving an injection, the injection can precipitate the paralysis into that muscle. That was happening. That was called a provocative polio. Now polio is not there, so that possibility is not there. So the intramuscular nerves can be injured, and that can result in an weakness getting localized to that area. Okay, so here there is lower limb weakness which has ascended up to the upper limb and then the lower cranial nerves. There is nothing to suggest a facial involvement. There is some altered sensorium and palatal weakness. And then the child required ventilation, maybe because of the pulling of secretion and alteration of sensorium, or it can be due to respiratory involvement also. So respiratory involvement, usually there may be some irritability can be there, and then the child cannot speak in long sentences. Usually we ask them to count 1 to 10, 1 to 20 without taking a breath. That is one way by which. So in this, what are the possibilities that you will think of now?
One is, ma'am, transverse myelitis is one of the possibility. I mean, it's increasing, so GBS can be present like this, ma'am.
Yes, GBS, the ascending weakness, symmetrical weakness starting in lower limb and then in the upper limb, and then the lower cranial nerve is affected with some alteration in sensorium due to various reasons. Okay, but what are the points that is a little odd?
GBS bowel bladder involvement is late usually.
It is not late. It is transient.
Transient. Okay.
So initially, if the bladder is involved, that is okay, but the bladder may not be involved persistently. That is, so early bladder involvement and persistent bladder involvement is more in favor of a myelitis. Okay. GBS also can have a transient urinary retention. Then what is the other point that is against? We said about pain, abdominal pain.
Paresthesia, that band. Paresthesia.
If there is a band-like pain or hyperesthesia, if that is there, that is very much suggestive of a starting in the code. So, a myelitis which might have ascended up. Otherwise, the first possibility we will be thinking about will be a acute demyelinating inflammatory polyneuropathy, which has affected the lower cranial nerves also. And then with the alteration in sensorium, we were thinking about the Bickerstaff or brainstem encephalitis also. Or it can be part of the ADEM. The other symptoms may not be that prominent. So these are the possibilities that we will think of when we are hearing the history like this. So on examination, we have to see what are the points for each and everything now. So from the history itself, we have to reach at the differential diagnosis. Okay. So it can be the code which might have ascended or extended up to the medulla. Okay, or the cervicomedullary junction, you can have the lower cranial nerve signs also. Or it can be a brainstem plus code involvement, that will be the Bickerstaff encephalitis. Without code involvement also Bickerstaff encephalitis. So this Bickerstaff encephalitis, GBS, Miller-Fisher, these are sometimes a continuum. What is Miller-Fisher syndrome?
Ma'am, it's a variant of GBS which contain areflexia, ataxia, and ophthalmoplegia.
So for that and for the Bickerstaff encephalitis, ophthalmoplegia is important. Ptosis and ophthalmoplegia. And in another, the difference is there is areflexia, but the weakness is not that dense. So the child will have at least grade 3 power. Okay. So Miller-Fisher has ataxia, areflexia, and ophthalmoplegia, but ataxia is more prominent and weakness is not that prominent. At least grade 3 power will be there. Bickerstaff encephalitis, when the brainstem is affected, you can have ptosis, ophthalmoplegia, then you will have alteration in sensorium, lower cranial nerves may or may not be affected, and there may be weakness also, which is of UMN type but in the acute stage, it will appear like a flaccid paralysis. But in a GBS, the abdominal pain, localized abdominal pain, that is like, it is very difficult to tell. And also in bigger stuff, also this abdominal pain as a prominent symptom, it is little difficult to explain. And the pain subsided after 1 or 2 days, or was it present after ventilation? You may not be knowing, isn't it? After ventilation, it is might have gone. When
No,
the child is extubated, it is not there.
No, there,
Isn't
ma'am.
it? Okay. 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 So continue.
On examination, general examination, the child appears lethargic, lying supine on bed with arms extended and by side. NG tube and Foley's catheter was in situ. The vital signs: heart rate was 68 per minute, regular, normal volume and character. All peripheral pulses are equally palpable. No radiofemoral or radio-radial delay. Respiratory rate was 32 per minute, abdominal thoracic, and there is work of breathing was normal. Temperature was normal. GRBS was 140 milligram per deciliter. CRT is less than 3 seconds. Saturation is 98% in room air. And BP was normal in all upper limb and lower limb, between 50 and 90%.
Okay.
General physical examination, there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy. Head to foot examination, there is no facial dysmorphism. Eyes are no ptosis, conjunctival normal. Face, no parotid swelling. No knuckle hyperpigmentation. Chest, single caveolate spot on 5 mm in chest, no rashes or exanthem. Abdomen was normal. External genitalia was normal. Spine, there is no gibbous and no contracture. Anthropometry.
This tonsil also, and the throat, if there is a patch, because diphtheritic is one possibility. Even though the child is immunized, that also you can mention.
Okay.
Okay.
Anthropometry, his weight was 24 kg between 10th and 25th percentile. Height was 136 centimeter between 15th and 75th percentile. Her circumference was 50 centimeter. BMI was 12.97 and between the underweight and normal. Developmental assessment, during the pre-illness period, the child
from
had...
the height and weight, can you tell anything? Like, height is between 50th and 75th percentile, and weight is 24 kg between 10th and 25th percentile.
Weight is underweight, but
the height is normal.
Yeah, ma'am.
Or on the higher, that is 50th to 75th. So that's a acute weight loss because of the illness, isn't it?
Okay.
So that it shows that it is an acute weight loss. Okay.
Okay. Developmental assessment. During the pre-illness period, the child had grossly normal development in all domains with good scholastic performance and good physical activities.
Okay.
CNS examination, higher mental function. The child was lethargic. AVP shows voice, and speech shows slurring. And memory is grossly normal and able to know his age and school. Handwriting was not.
Child answering to questions. What is about the comprehension?
Is answering, ma'am.
Okay. So the comprehension is normal. He is able to tell what time of the day, the orientation to time, person, place, all this you can say. This is a bigger child, isn't it?
Yes, ma'am.
Because when you are telling lethargic, we will think about it, the child is not able to do anything. So the child is actually, maybe the child who is extubated, the child will be definitely tired. But the child is able to tell answer to your question, even though the speech is not that clear, maybe partially due to the intubation also, though his volume will be less. But the child is able to recognize parents, recognize the doctors, the time, place, person, where he is. All these you have to tell. Okay.
Okay. Handwriting not assessed. Gait is not assessed.
Not assessed cannot be done, isn't it?
Okay, cannot be done. Cranial examination.
The child is having weakness, severe weakness, isn't it? Okay.
Yes, ma'am.
And I think the gait can be told only at the motor examination. That will be better, because if the child is walking, the whole of neurological questions will come at the time of gait examination. So I often prefer gait to be done after the motor examination. So it may be different at different people, but when a child is walking, when you are discussing the gait, the most of the diagnostic points will come there. Okay. Okay, continue.
Cranial examination. First cranial was normal. Second cranial visual acuity recognized mother. Field of vision could not
By
be done.
visual acuity, you said recognizes mother.
Ma'am, actually he was bed in the bed,
Okay.
so
This is a child who can comprehend. You can
yeah,
give something to read, isn't it?
yeah, ma'am.
Because this is important in this child.
Okay.
Is the child having a visual impairment? So you can say that the child can read at least the bigger prints in the newspaper or whatever is available. Or you can give your chart, Rosenbaum's chart you can give. At least child is reading 2, 3, 4 lines and then the child becomes tired. But you can make him read. Okay.
Color vision is grossly normal. Fundus was normal. 3, 4, 6 cranial. There was no ptosis. Extraocular muscles movement were normal.
So fundus, definitely you have to examine for this child. Okay.
3, 4, 6 cranial. There was no ptosis. Extraocular muscle movement were normal. Pupil was bilaterally equal and reactive to light. Direct and indirect light reflex was normal. There was a horizontal nystagmus. And fifth cranial sensation on the face was normal. Corneal reflex not done. Conjunctival reflex was normal. Clenching of the teeth was normal. Jaw jerk was not exaggerated. Seventh cranial there is no.
What can be the reason for the nystagmus?
Ma'am, any.
Is it present on both sides? A child is looking to either side?
Ma'am, both sides it was there.
It is equal bilaterally, or is it present at the extremes of gaze, or is it?
It is present the extremes of gaze, ma'am.
So a mild nystagmus can be normal, but if it is prominent, how will you explain? A child who has a involvement of palatal muscles and
the cerebellum.
So cerebellum or its connections.
Okay.
So brainstem has got connections with the cerebellum using the 3 peduncles, the superior, middle and inferior. So if the demyelinating event affect any of these regions, you can have this one. Second is if the child is getting some medications which can produce nystagmus. Often anti-epileptics, sometimes people may add it empirically also in a child who is having a decrease, sensorium is altered, some people may add, and then your Fenta, all these can have some amount of fentanyl also, I don't know exactly, but maybe. So drugs is one possibility often in a child who is having multiple medications. And another one will be the involvement of the brainstem cerebellar pathways. Okay.
Fifth cranial sensation of the face was normal. Corneal reflex was not done. Conjunctival reflex normal. Clenching of the teeth was normal, and jaw jerk was not exaggerated.
Jaw jerk is present or not?
Present, ma'am.
Okay.
Seventh cranial, there is no facial asymmetry. Able to close both eyes. Nasolabial fold was normal. There is no deviation of angle of mouth, and taste was normal. Eighth cranial response to voice, ma'am.
Here, you said able to close both eyes. So you can ask for the frowning also. Is there any this frontalis activity is coming, isn't it? So we can say that whether it is upper, lower, like that. Now, so try to do that also. Okay.
Eighth cranial, there is response to voice. Ninth and 10th cranial, ula was central. Palatal movement was equal bilateral. Gag reflex was absent. There was a difficulty in swallowing and pooling of secretions. And 11th cranial, they're able to move.
There is a little disparities there. Palatal movement is equal and bilateral is there. But there is a difficulty. Difficulty in swallowing will be seen usually in an intubated child. But some pooling of secretions is there, which may be due to various reasons, but pooling of secretion is one point. And gag reflex, absent gag reflex, will that tell anything?
So, bulbar palsy, ma'am. Ninth grade.
Actually, normal persons also can have an absent gag reflex. So palatal movements, according to you, is equal. Okay. And the uvula is central. So maybe child may be improving. We don't know. But gag reflex is absent. Along with other signs, it will be significant. But normal people also, sometimes it can be absent. Okay. Okay, continue.
11th cranial law, able to move grossly normal. 12th cranial law, no fasciculation of tongue, no atrophy, no deviation of tongue on protrusion. Motor system, the posture, the child was lying in supine, arms and legs extended, bulk of muscle, no wasting. And upper arm, there was right 16
In the initial
centimeter.
part, you said the limb was kept externally rotated, isn't it? That you can tell. Okay. So there is no wasting. Continue.
Upper arm, there is 16 centimeter, and lower arm is.
So here the centimeter doesn't matter. It is equal bilaterally. Okay.
Tone, generalized hypotonia in all limbs, leg extended at the hip and knee, external rotated and plantar flexed. Range of movement increased in all joints.
Okay. In upper limb as well as lower limb, there is hypotonia.
Yes, ma'am. Power of muscles, right and left, we got shoulder, elbow and wrist is 3/5, and knee angle, hip and knees no power, and angle I got 1/5.
Okay, 3/5, and this hand grip and fingers and all, we won't usually say grading. We'll say hand grip is weak. Because 3/5, how will you say about hand grip? It's very, very difficult. Then, okay, lower limb, only some flicker of movement is there in the, is it in the ankle or is it in the fingers?
It is the fingers, ma'am, actually.
Yeah. So you can say there is a flicker of movements in the fingers, toes. Okay. And what about, okay. Neck flexion 3/5. How did you do the neck flexion in the lying down posture, isn't it? Is the child able to flex it?
Ma'am, actually, when he brought, means elevated the coat and asked to do.
Then is it 3/5? When you are elevating the coat and then ask the child to flexion, is it against gravity?
Ma'am.
Actually, it is with the gravity eliminated. When the child is in the lying down posture, it is against gravity.
Oh.
You are raising against gravity. When the child is in the sitting position, actually, you are not doing against gravity. With gravity eliminated, you are doing. So if at that time the child is able to do that, that is grade 2. When the child is able to lift in the lying down posture, it is grade 3. Okay. Okay, continue.
Ma'am,
okay.
This is the video of child is able to lift his during the course of time.
Okay.
Ma'am, reflexes, deep
so
reflex.
You have shown the elbow as flexed. Can you do is the shoulder also like that?
Ma'am, this is a video in between, so.
Okay. So if you are showing, actually you have to show all. Just one means we can say that the elbow is having at least grade 3 power. That is the only thing that can be said. Okay, continue.
Reflexes, deep tender reflexes, I couldn't get any biceps, triceps, supinated knee and ankle. And superficial reflex also, I couldn't get any reflexes, ma'am, at time of examination. So total reflexia was there, ma'am.
Okay.
Sensory system, the superficial sensation, touch, pain, and temperature was normal. Deep sensation, vibration position is not elicited. And cortical sensation also not elicited. Cerebellar side,
how will you assess the pain or the sensation in a child? Just say paraplegia. Okay. How will you assess the sensation? From where you will start doing it?
Ma'am, for touch, we have to do along the dermatomes. So from the distal to the upper part.
Because always from the abnormal to the normal side.
Oh.
And one thing is, what I have found useful is actually you have to first touch the foot and then touch the forehead and ask them whether there is a difference. That will be a very gross difference. If there is a gross difference, they will tell. Otherwise, if you are going on one point like that and asking whether you are feeling it normal, abnormal, then it will be very difficult for them to tell. So sensory testing you should do very fast also, and from abnormal to normal area, and sometimes just using the back of your knee hammer, you can just go up, and suddenly at the area of hyperesthesia, they may sometimes complain of an increase in the sensation. So that will be the level. Otherwise, you will not get the level. And if you are asking whether you are touching the foot and asking, are you feeling the sensation? They'll say yes. And the upper limb also, they'll say yes. Is there a difference between that felt in the foot and the limbs, or foot and the face? And then slowly you have to just go on relatively fast and identify whether there is, sometimes the child may wince. If there is a little pain, the child may wince at the site of hyperesthesia. That is how we identify the sensory impairment in a child, especially with a transverse myelitis like that. Okay, but the sensory level doesn't have much value in localization, as now we are seeing very long segment demyelination and we are getting a sensory level. But still, yes, identification of sensory level is very important, because it will most of the time will localize your lesion to the, if it is bilaterally symmetrical and all, it will be to the spinal cord. And both sides, if there is a difference also, you have to see one side and the other side, you can touch and see whether there's a difference. So very rapid, and you have to don't confuse the patient, ask like that, and give the same amount of force also. So always try to do that in all cases with especially spinal cord involvement, those who are admitted with paraplegia, then only you will be able to identify that. Okay.
Cerebellar signs, there was nystagmus, speech, there was mild slurring, and not able to assess the finger, nose, knee heel, and dyslexia of kinesia.
So in cerebellar spine signs, if you are telling mild slurring, so we have to see whether it is due. It is a cerebellar type of speech. What is a cerebellar type of speech?
Scanning type.
It can be either scanning or staccato. So scanning means slowly giving equal force, but it will be like Thiruvananthapuram, like that. Slowly they are telling, or they may be giving undue force in between. So if these two types, it is not these two types, then the slurring may not be cerebellar. Okay. If it is due to the palatal weakness, it will be having a nasal quality. And in the extubated child, it is very, very difficult to say what is the type of speech. And the volume also will be very low, because the vocal cord is, you have put the tube between the vocal cords. Okay.
Autonomic nervous system, the bladder was catheterized and he had constipation. And skull and spine, there was no deformities.
And did you try by blocking, keeping the catheter, whether he's feeling the sensation or not?
Ma'am?
The child is having a catheter in situ. Did you try whether the bladder signs have come back?
I just once tried, ma'am. At that time, he didn't feel any sensation, ma'am.
Okay. So just tell very between an UMN bladder and an LMN bladder.
Ma'am, LMN bladder, there will be hypotonic, hyporeflexic bladder, ma'am. And
okay.
UMN, it will be a.
So what you will get? What will be the patient's complaint?
Overflow.
So they may not, if motor and sensory part can be denervated separately, but if both are all are affected, the bladder will go on filling, they may not know. And when the bladder is enlarged to a certain degree, then there will be some dribbling. So retention with overflow incontinence. Okay, that will be the commonest type. So in all cases of acute weakness, whether it is LMN or UMN, you will get like this. But when it is UMN, what are the signs that we will get? Because now the child is in catheter, we will not get that. So a UMN bladder, what will be the symptoms? Because this child is having involvement much higher than the lower motor neuron site, isn't it? Okay. So a UMN bladder, what will be the features?
Spastic bladder.
So what will be the features?
It will be the frequency, urgency will be the ma'am.
Urgency, precipitancy, and
Frequency.
frequency. So that it will be the spastic bladder. Okay. So the child will be before reaching the toilet, the child will. Okay. Then there are other bladders, frontal type of bladder, whether they have a social incontinence.
Neurogenic bladder.
Then pontine are all there, but mainly in if it is the frontal lobe involvement, it will be a social disinhibition. So the person will have continence actually, but he won't look for a good place to pass urine. They may be passing urine in the room itself. That is called the social incontinence. Okay, continue.
Skull and spine, there is no deformities, kyphos, scoliosis, gibbous, swelling, or no tenderness. Major signs, there is no neck stiffness, chronic signs and bruising signs was negative. And peripheral nerves, there was no thickening. Other systems, respiratory system, upper respiratory tract was normal. Lower respiratory tract, on inspection, there was no nasal flaring. Trachea was central. Shape of chest was normal. Chest movement equally bilateral. Palpation confirms the inspection findings. Trachea was central. And tactile vocal phrenitis, there will be increase in the right infraclavicular area. Percussion present in all areas of lung field, and auscultation air entry bilateral equal. Crepitation was present in the right infraclavicular area. Vocal resonance increase in the right infraclavicular area.
So what is the diagnosis in the respiratory system?
Ma'am, a lower respiratory infection, mostly any pneumonia, aspiration pneumonia. Something.
What will be the word that you will use when there is no case and there is no shift of the mediastinum, there is an increase in the vocal resonance, and there is a localized crepitations in that area? Bronchial breathing is not there, but this increase in VF and VR are suggestive of a consolidation, isn't it?
Yes,
there will be a focal area of consolidation on the right infraclavicular area. Okay.
Madam, ഞാൻ ഒന്ന് എല്ലാവരും ഒന്ന് മ്യൂട്ട് ചെയ്യണേ. I'll kindly mute everyone.
Upper GAT normal, right?
Arif ഒന്ന് unmute ചെയ്യണേ. ഞാൻ ഒന്ന് മ്യൂട്ട് ചെയ്തായിരുന്നു. Unmute ചെയ്തു. Arif. Asif, sorry.
Upper GAT, there was normal. Riles tube in situ was there. Per abdomen inspection, shape was normal. No visible peristalsis, distension, scar, or dilated vein. Hernia orifice was normal. External genitalia was normal. Palpation was soft. There was no organomegaly. Percussion, no shift in dullness, no fluid thrill. Auscultation, bowel sounds normal, no bruit. Cardiovascular system inspection, pulse rate was 68 per minute, BP was 108 per 60 in the right arm supine position. JP was not elevated. Apex beat was in the fifth left intercostal space in the midclavicular line. Palpation, apex beat confirmed the left fifth intercostal space in the midclavicular line. There is no pastoral heave. Auscultation S1 and S2 normal. There is no murmur. Summary, a 9-year-old male child born to a non-consanguineous marriage, late preterm, with 35 weeks.
So that late preterm and all, you just leave it off.
Okay.
History of cough and rhinitis.
With the history of cough and rhinitis, fever, vomiting, headache and abdominal pain, followed by progressive weakness in the bilateral lower limb and upper limb, and with the pooling of secretions, slurring of speech, altered sensorium, and the child
So
was mechanically.
in this child, you have had weakness that has progressed for few days, then needed ventilation, and after that, the child, the sensorium has improved, and the child has started moving the upper limb also. So, a weakness that was subacute in onset, then it has progressed for 3, 4, 5 days, and after that, with treatment, that there is an improvement. The child has started improvement. One is in the sensorial improvement is there, and there is improvement in the movement of the upper limb. Okay, so a subacute onset, progression for some time, and then there is an improvement. So that is the tempo of the illness. Okay.
With the on examination, child was lethargic, tachypnic, generalized hypotonia in all limbs. Nystagmus is the slurring of speech and pooling of secretion, with the grade 3 power in the upper limb and grade 1 power in the lower limb. Areflexia in the upper limb and lower limb. Plantar there is no response bilaterally, with the NG tube and bladder catheter in situ. And on auscultation, there was crepitation on the right infraclavicular and right axillary area.
So the examination findings here. Okay, continue. Okay. So sensation also you have to take special. You have to examine properly. Sometimes there may be you may get a sensory level if you are examining like that. Okay. Okay, continue. So from this now, okay. So acute. Continue. So the diagnosis is an acute flaccid paralysis. Okay.
With quadriplegia, with bulbar palsy, with the bladder and bowel dysfunction, and aspiration pneumonia.
This bowel dysfunction is one thing that is not very, because any child usually on ventilator or other, there may be constipation. So bladder dysfunction alone, you can say bladder and bowel, because that is any condition can cause constipation, and all type of whether it is UMN or LMN, it will be constipation only. So bladder dysfunction is more significant. Okay. And aspiration pneumonia, rather than telling aspiration pneumonia, you can say that pneumonia in the right lower lobe or something like that, whatever lobe you can say.
Okay.
So the possibilities?
Possibilities, one is the acute demyelination disorders, acute ADAM, and other is GBS, Guillain-Barré syndrome.
What is the difference between this ADAM and GBS?
Ma'am, GBS, it's a element type palsy.
So it is a peripheral demyelination. Okay.
Yes.
ADAM is a central demyelination. So brain and spinal cord. In very small percentage, like 5 or 10%, there can be an associated peripheral nerve involvement. But predominantly, ADAM and multiple sclerosis are central demyelinations, and GBS is a peripheral demyelination. So always before telling the exact etiological diagnosis, we have to localize. Okay, just like what we have mentioned. So because it started with lower limb and there is some abdominal pain or sensory symptom, and then there is a bladder involvement that is persisting, a spinal cord involvement that have ascended up, reached up to medulla, lower medulla. That may be the one localization. So GBS plus a brainstem involvement.
Yes, sir.
Okay. And the second will be, no, not GBS, myelitis, transverse myelitis, or that is the ADAM involving mainly the spinal cord extending up to the medulla. There may be brain part also may be affected with Okay, that is one. Then if it is a peripheral nerve involvement, a GBS, that is also affecting the cranial nerves. So what is a little atypical for GBS here?
What, ma'am?
Anything atypical for GBS or peripheral demyelination?
Ma'am, GBS typically is
Please
the
mute. Okay.
involvement of central nervous system is altered sensory is one of the
Okay,
against.
that we have mentioned. If there is a hypoxia, respiratory muscle involvement, it can be. So what else?
Other is, ma'am, against.
It is ascending from lower limb, then going up. Then the cranial nerves are also, lower cranial nerves can be affected. So this abdominal pain, we don't know, but that is one. And that bladder involvement is remaining persistent. Even after extubation, the child is not able to pass urine. So it is remaining persistent. That is one point. Then one more is, usually in GBS, even when it is affecting the upper and lower limb relatively mildly, there can be a bilateral facial weakness. Here the facial weakness is not there. The lower cranial weakness is there, but the facial weakness is not there. So that is a point that is not very characteristic of GBS. Can you get any sensory symptoms in GBS?
Sensory.
Can you get any sensory signs in GBS?
Sensory sign. Touch and
Touch, pain and temperature, usually we will not get any sensory signs, but there can be paresthesias. So the child will be telling that in the sole, etc., there will be severe paresthesia. I cannot touch the foot on the ground, like that. So you can get paresthesias, but this abdominal girdle-like pain or hyperesthesia is not very characteristic. Okay. So otherwise, it can fit into a GBS, except that the facial involvement is not there and the bladder symptoms are relatively more persistent. Okay. Hypotonia, hyporeflexia, all are same. Plantar is mute only. If the plantar is extensor, that will be a point against an upper motor neuron involvement.
Yes.
So if we are just localizing it to the brainstem, usually the sense, to say it is brainstem encephalitis, one criteria is the external ophthalmoplegia should be there. Ptosis, as well as usually vertical eye movements are more affected. Ptosis and ophthalmoplegia should be there. Alteration in sensorium, then lower cranial nerve palsy, okay, and there can be weakness. And if you are getting an extensor plantar, then you can just localize it to the brainstem encephalitis itself. But usually this weakness may not be this much dense. So sometimes we may get a overlap between brainstem encephalitis and GBS, because the antibody is the same. The anti-ganglioside antibody GQ1, anti-GQ1B antibody. So Miller-Fisher also, the antibody is the same. So Miller-Fisher, you will get areflexia, but the weakness is not that severe, and ataxia may be prominent. Weakness will be at least grade 3 will be there, and ptosis and ophthalmoplegia will be there. So when the primary symptom is ptosis and ophthalmoplegia, we will think about Miller-Fisher brainstem encephalitis and the combinations. Or a hyperacute onset of myasthenia gravis also, you have to think whenever there is a ptosis and ophthalmoplegia. If it is myasthenia, what will be the symptom you will be asking for?
Weakness usually in the evening and
So
to improve in the morning.
So that is called diurnal variation. Okay. Second is fatigability. So if the ptosis, if you ask the patient to look up for some time, the ptosis increases. So fatigability and diurnal variation. These are the two words that we will always say whenever we tell about the neuromuscular junction. And the deep tendon reflexes will be preserved. Okay. And facial weakness also is characteristic, and overcranial nerve involvement is also characteristic. Okay. Then autoimmune encephalitis. Anyone for that? Then porphyria, definitely you have to think about as a cause. It also causes a peripheral neuropathy. There is an associated abdominal pain. You can say the peripheral neuropathy is there and associated abdominal pain is there. So you have to keep the urine for some time to see whether there is a change in color. And you have to do the urine for porphyrins. Okay. Then autoimmune encephalitis. Is it a possibility? Why? How?
Any infection, pre-infections may precipitate, or a vaccine can precipitate. So he had a history of fever, cough.
No, not like that. Then we can say that any child with fever can have autoimmune encephalitis. That is not correct. So along with this one, if second possibility, you have to tell about a viral infection itself, because there is not much difference between the onset of respiratory symptoms and the second symptoms. So it can be a viral disease that is affecting the brainstem and the spinal cord. Okay. So that we call it as rhombencephalitis plus myelitis. Okay. The another word that is mentioned is the acute flaccid myelitis. It can be due to enterovirus. It can be sometimes due to JE. It can even be due to influenza also sometimes. So many viruses can affect, and rabies also is a rhombencephalitis. So brainstem will be affected, or sometimes it can be the spinal cord also. So a viral myelitis or rhombencephalomyelitis can be the possibility. Okay. So the brainstem or brainstem encephalitis can be of two types. One is due to virus, one is due to the demyelination following the viral infection or along with the viral infection. So when we say Bickerstaff encephalitis, we believe that it is demyelination, but it can be due to primary viral infection of the brainstem also. Now both are actually together. There can be some inflammation setting in, and so most of the symptoms are due to the rather than the neuropathic effect, it may be due to the associated inflammation also. That is why most of the cases we give primary viral antiviral drugs. Along with that, we will give immunosuppressant also. So now the boundary is not that stiff, isn't it? It can be both. So first you can say peripheral demyelination, central demyelination. Then you can say an acute viral rhombencephalitis plus or minus myelitis. Okay. Autoimmune encephalitis, when we say autoimmune encephalitis, different types have different manifestations. Okay. Can it be an NMDA? NMDA, the presentation is not like this. Okay. So there is some alteration in sensorium, seizures. Then there will be some behavioral manifestation, irritability, psychosis. Then there will be abnormal movements, loss of speech, loss of sleep, like that. So that is NMDA. Sometimes may present with dystonic features, faciobrachial dystonia, and like that. Some may affect the basal ganglia that may present with movement disorders. So different types have different features, and because here the spinal cord and the brainstem is affected, we cannot say that autoimmune encephalitis. Brainstem encephalitis or Bickerstaff encephalitis definitely is a possibility, but except for the band-like and abdominal pain that was very severe in the initial period. Okay. Then multiple sclerosis. What is your opinion?
To exclude the diagnosis, so it has to be disseminated in time and space. So next.
So disseminated in time and space, that is important. And there are actually certain features by which we can say that this may or be or may not be possibility of multiple sclerosis. One is this encephalopathy as such is not a feature of multiple sclerosis, but in children in the first episode there can be some encephalopathy, but usually in an adult the encephalopathy is not there. Then this myelitis is a very short segment myelitis, and you will get only mild weakness, not a very severe weakness. And this rapidly ascending weakness producing a great zero power is usually not seen in a multiple sclerosis. Then optic neuritis, if it is present, is a very good point for and multiple sclerosis, that is usually unilateral. And ataxia. So one time they may come with ataxia, another time they may come with weakness that may be for a small segment. There may be some paresthesia, a little bladder involvement, sometimes recovering by itself. Then there are certain signs like a sensation when you are flexing the neck, there will be a sensation that is coming down the thing like that. So there are certain features of multiple sclerosis. Otherwise, in all Adam, we are not usually suspecting multiple sclerosis. Okay. So any other possibilities? Anyone thinking differently? So, can demyelination occur so early in 2-3 days of onset? Dr. Shija has asked. But demyelination can occur in 2-3 days actually. Sometimes it can be very fast. And GBS we have discussed. Campylobacter infection GBS is a motor only affected GBS, but this abdominal pain is not very characteristic. And the bladder symptoms that is persisting. Element finding again is because this is a why we are thinking of a UMN or spinal cord cause here, because this is in the stage of spinal shock. Okay. So you will not get any reflexes. You will not. There will be hypotonia also. That is the usual history in the first 1 or 2 weeks. Actually, the child now the disease is child is 1 more month into the illness. Now the child is able to walk and all according to him, and so if we have examined now, we can definitely say that whether it is an LMN or UMN. Okay. Okay. Just continue.
These are the investigation we done. Complete hemogram, HB was 10.8, total count was 6,370. Out of this, neutrophils are 83, lymphocytes 9. The platelet was normal 2.9, ESR was 33. Urea was 26 and creatine was 0.5, it's normal. And CRP was 31.9, LFT was normal.
This sodium, potassium always you have to see, because there is an entity called hypokalemic periodic paralysis. It will not last this much time. If there is a family history also, we have to think about that. Okay. Then continue.
From CSF analysis, total cells was 180 at the time of admission, and I repeat after 3 days, it was total cell was 120. Out of this, neutrophils was 2 and 98 lymphocytes, and second time it was 4 and 96, and proteins was 261, and it was increased actually in 300 in after 3 days. Sugar was 44, and next time it was 76. And
so what about the CSF analysis? What is your interpretation?
There is a mild pleocytosis with the mild increase in the proteins.
Pleocytosis, which type of pleocytosis? It is a lymphocytic
Lymphocyte.
pleocytosis. With a rise in protein, sugar 44. We had to know the
GRBS was 120, ma'am, at that time.
At that time. Did you give any glucose immediately before that? Because CSF blood, this value should remain if there was a mild hypoglycemia or something and you are giving glucose, the blood glucose will rapidly rise, but the CSF will take some 2 to 3 hours. In that time, you can get like that. Otherwise, so 76 and 44 is not that bad, isn't it? It is not half, it is more than half. So sugar is okay. We can say that the sugar is normal, but the protein is a little high. So we can say that this can be suggestive of a viral infection, and because the protein is a little high, we will keep in our mind the possibility of a tuberculosis also. Even though 300 is not that high, usually when we do it in viral, usually we may not get. Any other way by which we can get a high protein without infection? Have you heard of Freund syndrome? So if there is a CSF block at some level, sometimes when the cord is very much inflamed and there is a CSF block, so the protein level can be a little elevated below that level. So that can be one possibility, but the protein is definitely high. Otherwise, the value is 110 cells with predominantly lymphocytes can be there in both the demyelination as well as in a viral infection. But the 300 protein is a little odd against this one. Okay.
The culture was no CSF culture was there was no growth. ABG was normal. Polymerase microencephalus panel was no organism detected. Acapulco 4 and MOG antibody, anti-MD antibody was negative. MS panel was negative. X-ray chest shows a patchy opacities in the right middle zone. And flu panel we got influenza type B, and blood culture and stool culture
is actually respiratory, isn't it?
Yes, ma'am. Yes, ma'am.
Okay. So that shows that it's an infection in the throat swab.
Yes, ma'am.
Okay.
Blood
to
culture.
say that it is infection in the brain, you have to get that organism from the CSF. Okay.
Blood culture and stool culture, there was no growth. Tropical infections like scrub, lepto, dengue, viral serology was non-reactive. Gene expert MTB was not detected. Pianga and Sianga was negative. EG was normal. Echo was normal. And this is a MRI brain which shows sulcal flare hyperintensity.
Pianga and Sianga was done.
Suspecting some vasculitis.
Okay, vasculitis. So other features are not at all there, isn't it? In MRI, there was something like that. That is why we have done, isn't it? Usually, Pianga, Sianga for what? Which condition?
Vagus granulomatosis.
And Pianga for?
I don't remember, ma'am.
Okay. So, if there are arthritis, arthralgia, if there is a hypertension, if there is any renal abnormalities, all these polyarteritis nodules is one thing that can think of. Vagus, other features, any nasal involvement, severe lung infection, something. Renal parameters. So, PAN as well as vagus are for Pianga and Sianga, but okay. EG was normal, echo was normal. Okay.
MRI brain.
So echo was normal is important because sometimes there can be a shower of emboli, which can cause, but this much involvement of the spinal cord is not that common. But brain, you can have multiple lesions. Okay.
This is a MRI brain which shows sulcal flare hyperintensities in the bilateral cerebral hemisphere. basal cisterns, more evident in the post-contrast FLIR images suggestive of meningitis, and a multiple acute lacunar infarct in the subcortical white.
Why it is suggestive of meningitis? Sulcal hyper post-contrast, maybe because of the post-contrast they might have said. So in meningitis, the sign will be the leptomeningeal enhancement should be there, isn't it?
Yes.
Yes. And sulcal hyperintensity is because of the surrounding encephalon is affected. So contrast enhancement of the meninges is suggestive of meningitis.
Yes.
Okay.
Yes, there was a multiple acute lacunar infarct in the subcortical white matter of bilateral cerebral hemisphere, bilateral coronal radiata, and centrum semiovale, likely vasculitis secondary to meningitis. There is no enhancing focal lesion. There was a transient lesion of splenium of corpus callosum. This was the report from the admission.
Okay.
And
Transient lesion of splenium of corpus callosum is one thing that is described in influenza. Influenza rotavirus. Next picture you just show. So you can see that in the, can you see the splenium that is in the posterior part? In the middle of that there is a hyperintensity. There is a red arrow there, isn't it?
yes, ma'am.
That is in the splenium that is between the two posterior horns. You will get the splenium which will be dark in color. Middle of that you are getting a white thing, a round one. That is the splenial hyperintensity, which can be seen in H influenza, which can be seen in rotavirus, sometimes seen in COVID, etc. Yeah, not H influenza, influenza virus. So influenza, COVID, and also rotavirus, you can get transient splenial hyperintensity. Sometimes it will appear like a boomerang. We call it as a boomerang sign. Okay.
MRI spine, which shows the dorsal spine, long segment, intramedullary, T2-weighted state hyperintensity seen involving the centrum region of the spinal cord from D8 to T12 vertebrae. Possibility of infectious myelitis. It was the first X-ray done and first MRI spine, and repeated after 3 days.
That is seen between D12 and D8.
Yes,
So
ma'am.
that may be the area of hyperintensity, area of hyperesthesia the child have experienced.
Okay,
Around a D8, D10 like that.
okay.
And the lower limb weakness was developed. If the level was D8 or D like that, only lower limb will be affected and upper limb will not be affected. And then it might have progressed. Okay.
After 3 days, showed progression of lesion to cervical spine and the brainstem.
Okay. So that is how it has happened. So it started from the lower level and then it has progressed up and up to the brainstem. That is why all your findings can be explained.
Yes,
so that is how if you are going systematically, you can localize the lesion. Okay. But this other vasculitis like or cytotoxic edema like symptoms, they are asymptomatic. Okay. So this can be a myelitis or this can be a demyelination. So myelitis, along with that, there is a inflammation and that is why it has responded to immunosuppressants. Okay.
This is the child now after 6 weeks, ma'am.
Okay. So the child is walking. We have to see there is a dragging, isn't it? Just display it once more. See, especially the right side, isn't it? Yes. Slightly child is dragging.
Yes, ma'am.
So if you have examined the child now, the reflexes might have reappeared and there may be more of distal weakness, especially of the lower limb, like that. And the sensory also sometimes you may get, but now sometimes the sensory may not be seen. Okay.
Thank you, ma'am.
Is Benno there? Anyone? Sir ഉണ്ടായിരുന്നു പുരുഷോത്തമൻ sir.
എലിസബത്ത് മാഡം ഉണ്ട് മാഡം, സുഷമ മാഡം ഉണ്ട്.
Elizabeth ma'am. സുഷമ മാഡത്തിനെ വിളിച്ചു നോക്കാം അല്ലേ? Ma'am, Sushma ma'am, are you there?
As well.
Sir, I haven't
Clinic,
seen in the sir your name. Okay.
Screen on off here.
Yes, sir.
Screen share stop ചെയ്യാം.
Madam പോയോ? Madam ഇല്ലല്ലേ സീനിയർസ് ആയിട്ട് പോയതോളല്ലേ? ഒന്നുമില്ല. I was listening to your presentation. So in this case, at this stage of history, before we examine 9-year-old child, previously normal, very short period of weakness, when they basically started in the lower limbs, then extended upwards, lower cranial, but there was an altered sensorium and headache.
Yes, sir.
So always in a analysis at the time of history should be going systematically, answer one by one. Is there a neurological lesion? Where is the lesion? What is the likely etiology, pathology, and the functional derangement? Functional analysis is important because you need to answer certain questions. What is the problem? What am I going to treat with it? And what are likely later prognostication? Parents will be asking. So we need to have answers to all of these situations. So at the stage of history, each of the history, you need to go a little more in depth. About the weakness part, the evolution of the weakness, whether it was simultaneously in the lower limbs, one followed by the other, or how was it evolving from the limb weakness? And all these things in the functional level you should be talking. So how many minutes or hours or days it will evolve? What is the pattern and evolution of the weakness? When we are talking peripheral or distal weakness, what about the truncal weakness? So that sort of a functional aspect was missing. To just jumped into this thing, a little more biased about the demyelination situation. So at this stage of history, you need to consider all the other possibilities.
Yes, sir, because the child was actually being treated as appendicitis from a local hospital for 1 or 2 days, and then the child was brought there, and this history, nobody knows about the history. And when the child was made to stand, there was buckling and child was not standing. That is a history that I could elicit from repeatedly asking. So there is no further histories available. That is a problem.
Okay. And in that situation, always the sensory involvement, you are asking the sensory, there was an autonomic. You need to ask about the pattern of sensory problem, the numbness, actual thing, and the autonomic problem also. When there is abdominal pain, you need to consider acute the botulinum toxin, lead poisoning. So you need to consider all the other possibilities also. Of course, a child developing weakness, gradually progressing for some time, gradually recovering. So, of course, the possibilities in this case is demyelination. Either it's at the peripheral only or peripheral plus central situation, likely, but other possibilities at that stage, also like sickling situations, hematological condition also can produce abdominal pain. So we need to consider past history, the sickness, sickling, heavy metal poisoning, botulism-like situation, vasculitis, drug reactions. All these possibilities should be thought of at the history level, especially in the past history part. The evolution you mentioned, and at the initial situation, there is a little bit of a skipping of the lesion. There was a weakness in the lower part and the lower cranial part. upper headache and the upper feeling was state. So at that stage itself, it cannot be explained by the spinal cord alone. It must be spinal cord plus central. So that is one process. So it's more than localization in the anatomically will be the. It is the, as Dr. Kalpana at the end told, the brainstem part is the definitely the spinal cord also. There's a little bit of skipping in between. So when you talk about the facial, in this case, bilateral facial paresis may be the. It's not the deviation only, bilateral weakness. So you need to include what is the problem? The whistling, straw sucking. So that's all important. Mild bilateral facial weakness. So in the history, that is important. And in the examination, the rate of pulse was 68. So when you get a lower rate, you need to consider, is it due to raised ICT? Less likely, because they can raise ICT features were not there. So you need to always be considering autonomic disturbance also when you're getting an unusually lower rate. In the sensory examination, whether it is what type of sensory, it's a tract type sensory loss, the modality, those details are needed because you are basically differentiating whether it's a peripheral or a central. So GBS or a parenchymal situations are the commonest DDs. The tract like of sensory lesion, that is argument for this bladder disturbance lasting for more than 72 hours and the tract type of sensory loss all fine against the simple GBS situation. It must be a parenchymal. So anyway, there's a good discussion. Kalpana, that's enough.
Thank you, sir. Thank you, sir. Always, when we are taking the history in detail, nowadays it is coming very much reduced, isn't it? This one or two sentences, the history will be over in now most of the places. So when you're taking it a little more time for history, we will be getting most of the diagnostic points as well as how to manage also we will be able, and the etiologies also we may be getting from the history itself. So always take maximum time for history, and examination we can finish in 5 or 10 minutes. That is the thing.
At the end of investigation, among the possibilities, as Shiji just suggested, when you are getting everything in a very short period, para-infectious demyelination is one possibility. Of course, infectious agent as such, Dr. Kalpana said, two different diagnoses, whether it is a demyelination central or infection as such response. So it's possible, out of which there are few treatable entities like mycoplasma situation, the other conditions, a few of them also producing this myelitis. You include that also in the treatment part. Among the demyelination, when Adam present just like this, one of the autoimmune is the MOG antibody. Aquaporin is less likely because NMO has NMO spectrum problems, ocular will be there, it's not there. When you're getting a longitudinal spinal cord problem, one of the possibilities, of course, is a MOG antibody also. In this case, it is done and ruled out.
Yes. So MOG and NMO both can be possible. Because NMO, optic neuritis, can occur later. It can come first, like so longitudinally extensive transverse myelitis. MOG and NMO are the two important differential diagnoses.
Kalpana, what about the imaging he showed in the initial imaging? Was it suggestive of an Adam? It's an ADA and the
because I have not seen the images. This is actually a diffusion weighted imaging that was shown there, and that was showing some focal areas of diffusion restriction. When there is diffusion restriction, we can say that it is a cytotoxic edema. So the commonest cause that is producing a cytotoxic edema will be an infarct, but a small a sudden onset of demyelination also can have some amount of edema. So a diffusion restriction by itself, we cannot say that it is vasculitis. Vasculitis is one of the possibilities. So when there is a meningitis or meningoencephalitis, vasculitis can be part of that also. So that is why it is reported like that. So para-infectious will be a better term than a post-infectious, because splenial lesion is there and this cytotoxic edema is showing so evidence of vasculitis due to the infection, and it has affected the brainstem as well as the spinal cord.
In this case, also antivirals given, Asif? So, Gopika comment was what is the treatment with IV gamma, of course, IV gamma.
Medial prednisolone കൊടുത്തു സർ, ആന്റിവൈറലും കൊടുത്തു, സൈക്ലോവിർ കൊടുത്തായിരുന്നു, ആന്റിബയോട്ടിക്സ് ഇട്ടായിരുന്നു നമ്മൾ.
Clover
oseltamivir കൊടുത്തായിരുന്നു, because influenza is one of the entities which need to be considered in the view of the splenium lesion, a treatable entity.
ഇട്ടിരുന്നു സർ.
So the influenza nowadays, actually it is producing a very severe hyperacute type of severe weakness, producing brain edema and death in 2-3 days, like that, very severe. And actually the Kerala government has issued a paper like that. In SAT there were many cases, and we also had 1 or 2 cases with very severe edema, herniation, death, like that. So influenza.
We had a few cases of B reported influenza B, but it has come down in the incidence recently. The Victoria, Yamagata, all has come down. It was there 2-3 years back, rapidly progressing, circulatory collapse, liver involvement, death, encephalitis and all. But
last year also in this, maybe in the southern regions, there were cases actually.
But in this case, viral markers were negative.
Only, but influenza was not tested in the CSF. Influenza was tested in the throat, that was positive. Okay.
Mohandas was there. Mohandas was there. Mohandas, പറയൂ.
സാറേ, ഞാൻ എൻ്റെ ഇടയിൽ യാത്രയിലായിരുന്നു. ഞാൻ തൃശ്ശൂരിൽ നിന്ന് മടങ്ങുകയായിരുന്നു. It was a nice presentation. I think the main symptoms were along with the infection features, child developed a neurological problem. So has told a para-infectious problem or a viral meningoencephalitis. When you correlate with the MRI findings also could be a possibility.
Yes, sir. When we say, definitely we had to say that the brainstem as well as the spinal cord should be involved. Then only we can tell. Otherwise, it will be very difficult to say.
When you are presenting in the examination, you need to read about the recent guidelines and all. Lot many questions will be asked about the grading, the criteria and the prognostication. All these things should be applied, especially when it's an AFP-like situation, ABS situation. In this case, a little bit different, more and more of a parenchymal involvement. But in a similar situation, when you're GBS situation, lot many questions can be asked in that part. How prognostication, what
and
are
also
the
AFP questions regarding AFP will also be asked. How the collection, where to be sent, all these should be asked. And then what are the indications for ventilation in a GBS case?
Ma'am, involvement of the brainstem. So with
GBS involving the brainstem is not that common, isn't it?
With the diaphragm.
So how do you know? When will you ventilate? Any criteria or anything? How will you monitor? Say, a child who is having lower weakness and slightly ascending. That is regarding the sensorium, but a GBS child otherwise having a normal sensorium.
When the single blood count.
Okay. Will you do a vital capacity or something like that? Or in ABG, what will happen?
Ma'am,
So your SpO2 will remain normal, isn't it? There is carbon dioxide retention happens. So
ma'am.
always do an ABG and see that the carbon dioxide is getting higher up. It is more than 60 or something. And also this single breath count is a useful investigation, but nowadays, because we do actually GBS needs a early ventilation. Vital capacity, there are values like 20 ml per kg or something. So if it is coming down, you have to ventilate. Early ventilation and late extubation, because the muscles are weak, and if you are immediately extubating, what will happen? Again, the muscle will be working and the muscle will become more weak. So slowly, using a T-tube, very slowly only you have to extubate in a muscle weakness or respiratory weakness case. So that all can be asked actually. And the settings all will be the minimum, but they may require ventilation for a longer time. Okay. Where is Benno?
Benno?
Yes, madam. So we'll wind up the session.
Okay.
So
Okay,
first
thank you,
of
sir.
all,
Thank you, Mohandas also.
Thank you, madam. It was a very
Thank you, madam.
exhaustive session, and we learned a lot, many things. And I'm sure the PGs would consider this a very valuable learning points.
Thank you.
Thank you, sir.
Yeah.
Purushothaman sir, Sushma madam, and Elizabeth madam was also there. I think they left.
So I think we'll wind up. So a special thanks to the case presenter, Dr. Asif K, and heartfelt thanks to our dear Kalpana madam for taking the session very wonderfully and teaching us new concepts and valuable inputs from Mohandas sir and Purushothaman sir. And special thanks to Gopika madam for mentoring the session. And last but not the least, all the audience for their patient listening. So we'll wind up. Thank you, madam.
Thank you,
Thank you,
IAP, for giving us a chance.
Okay.
Thank you.
Thank you.
Thank you, sir.